So welcome for the last workshop in this series for the IAPT top-up training. And we're going to focus on supervision in this half-day workshop. And let me just share the screen for a few housekeeping things.
You're right.
So just to remind you, if you could mute yourselves when you're not speaking, and make use of the chat function for any questions you may have. We will have regular opportunities to address your questions. And finally, you probably get the best view where if you select speaker view, because then you see the speaker and the slide. And let's look at what we're going to cover today. So first of all, Rachel Handley, who you met in the first workshop, will talk about supervision of trainees and decisions. Then we'll have a break. Then Sheena Linnes, who has kindly joined us for this session, will talk about supporting and assessing competency. You will have in your handouts the materials we need for this, the competency rating scale, and especially one particular one that you'll use in an exercise. So if you don't, we'll put the handout again in the chat as well if you haven't downloaded it yet, so that you can access that material. And then we'll have another break, and Emma Warnock-Parks will join us then talking about tips for supervision and also attending to therapist appraisals and a bit on self-care. And we will have time for question and answers at the end as well. I'll make a note of those that we don't answer immediately. And we're hoping then to finish at around 1 o'clock. So not after, but around that time. Emmy Harris, who some of you may have seen in another workshop, is assisting us today. And if you have any problems, feel free to email Emmy. This is her email address, Emmy Harris, and you will have her probably from previous emails as well. And then finally, I wanted to mention something about the, sorry, I hadn't made it big enough, I think, to make a note of which breakout room we will ask you to join in the course of the day. It's different from the previous workshops where we assigned you randomly, but as you know each other now through the supervision, we thought it might be nice if you could do the breakout rooms also within your supervision groups. And you see the names of, oh, this is the wrong slide now, isn't it? Oh dear, sorry. I added it to the wrong slide. So we have to, Emmy, you may need to help me here. I'll update it for when we have the first breakout. So Richard has Monday and Tuesday. I think Monday and Tuesday is the is group 1, then is Thursday group, and Carrie Young's group 2, and so on. This group 1 is at 12:30. So hopefully you can identify the group that you are in and take a note of that. But we'll update the slide and then I'll show it to you again when we have the breakout rooms. So let's stop sharing. So and then without further ado, I would like to hand over to Rachel, who will now take you through the first topic of the day.
Good morning, everyone. I'm just going to share my screen, which is first technical hitch of the day. The screen's not allowing me to do that.
It's really annoying. That's right.
Emmy, I wonder if you've got the slides to hand, do you? Because
Yes, let me just find them.
Apologies. All set up to go here, but the screen, oh, here we go. For some reason it's not allowing me to do this.
Try again, Rachel. I have now allowed the sharing screen for everybody. As a co-host, normally you could be able to do it, but maybe it will work now.
No, it's not. I'm sorry.
I can share them.
Okay, yeah.
Apologies, folks. It's a good start, isn't it? But hopefully that's the one technological hitch for the day. I'll be responsible for it, and everything else will go really smoothly. So I'll channel my Chris Whitty, and we can and say next slide, please, when we need it. So I mean, just the first slide. That's brilliant. So as Anka said, today's focused on supervising PTSD, cognitive therapy for PTSD. And as you'll know, this training was funded to support the development of cognitive therapy for PTSD skills in IAPT, because and where the outcomes haven't been comparable to the development of other disorder-specific interventions. So there's like a gap between the kind of what we would be expecting to see in terms of the RCTs and the evidence base and what's happening on the ground. And there may be lots of reasons for that. But in parallel, trainees on the high intensity IAPT programs are also now required to take PTSD cases on whilst they're training. Because one of our hypotheses was that actually, because people weren't getting that experience in training, they weren't building that confidence early on to do that. And the idea is they could develop those skills under close supervision during their training. So the hope is that you're going to emerge now from this program not only confident, competent, expert even in cognitive therapy for PTSD, but also that you'll be equipped by your experience to more confidently supervise other therapists. That's both trainees and qualified therapists within your service. And you could have the next slide, please. Thank you. So IAPT supervision guidance notes that the key role that supervision plays in ensuring positive outcomes for clients. And that's why we made such a significant investment in this training in your supervision. So we've had lots and lots of supervision over a good period of time. All the RCTs in which the evidence is based have included extensive supervision, so we can be fairly confident that's important even for trial and expert therapists. Next slide, please. So IAPT supervision guidance also notes the key functions of supervision, and our experience is that these have been highlighted by our supervisees on the programme in particular, and if we could just click to show some highlights with respect to fidelity to the evidence base, skills development and training, and also what supervisees, and I don't know if it's been your experience in your groups, but actually just that experience of being really held in supervision, having that close supervision has really helped support people and really been a kind of an oasis of calm and development and stretch and sort of that intellectual and practical skills development that people really need, that helps that kind of prevention of burnout and allows people to feel really supported. Next slide, please. So because supervision is so critical for all of those functions, IAPT programs everywhere deliver extensive supervisor training, and this morning isn't meant to replace that. They're usually 5 days in length, and they go through all the kind of competencies of supervision, which many of you will be aware of from the Roth-Pilling framework. But actually today we want to focus particularly on the cognitive therapy for PTSD piece in the context of those supervision skills, and the focus will be particularly on the applications of supervision to specific models and competencies, including the supervision of CBT and the meta competencies, higher order decision making. If you just click on one, please. So it's kind of, and click again, I think we'll circle those. So, and again, so it's those two areas, the kind of the supervision of CBT and the meta competencies, which we'll be talking about particularly today. Thank you. So you'll be aware there are different types of supervision in IAPT, and we're aware that often in busy IAPT services, the clinical skills bit is often the bit that gets a bit squeezed because time gets focused on case management and throughput and review. And so many cases that people are seeing, it's kind of hard to have that really in-depth focused supervision on clinical skills. So for the next 8 minutes or so, we're going to divide you into breakout groups in a moment. Just have the next slide, please. And what we'd like you to do is just have a bit of a chat about your experience of supervision on this programme. So thinking about particularly, what are the similarities between usual CBT supervision and cognitive therapy for PTSD supervision, such as the supervision you've had on this programme? What are the similarities? What, if any, are the differences? I promise you we're not doing stimulus discrimination. I've just realised I've used that formula. But what are the similarities? What are the differences? And what would you like to take forward into supervision yourself as you're going forward? And when you come back in about 8 minutes, we'll just ask you to put a bit of feedback in the chat on the side, and then we can have a little look at that. Thank you. So as everyone is coming back in, if you can start putting some of your thoughts in the chat around the similarities and differences, around the supervision you've experienced here, your usual CBT supervision, and what you'd like to take forward. People are still in their groups.
This meeting is being recorded.
So anyone brave enough to start typing in the chat, or feel free to feedback verbally if that's easier, what you notice about the similarities and differences in your usual CBT supervision and the kind of supervision you've been having recently, what you might want to take forward. Okay. There's more reflection, lots of similarities around looking at formulation and techniques. Group supervision looks like it's being valued, being able to learn from each other. Yeah, often we can get sort of into those sort of dyads, which can be really useful for some in-depth parts of supervision, but also you miss out on that learning from other people. Sounds like there's been different quality of supervision. I hope the quality has been good on the programme. Fidelity to evidence base, and one approach rather than lots of everything. Yeah, and that's, you know, as we grow and develop as clinicians, obviously we kind of read and we learn and we draw on other things, but it's really important to keep that balance between the evidence and the fidelity to the evidence base and those kind of skills that you pick up as you go along. Positive experience working with comorbidity and complicated PTSD. It's been a bit of a focus on that, which is great. And we know that, and I'll come on to talking about this, that, you know, there's no such thing as a simple PTSD case in IAPT. You know, we love to think that there's, you know, lots of people out there with one adult trauma that we're working with, but we know that that's not often what's walking through the door, or who is walking through the door, I should say, at IAPT services. Bringing recordings, great. It's really good to hear that that's been happening. It's a key part of this treatment. We know it's something that is just so critical to good supervision and to that really close skills focus. Working through the full treatment under supervision, yeah, it's really hard, isn't it, when you're in your normal supervision, not to just dip in and out of different cases at different points. And there's a huge value in seeing cases from start to finish under supervision, really kind of help you see where your gaps are, where your areas for development are, and to really again just make sure that protocol, that that evidence base is being applied well throughout. Lots of formulation and check-in similarities, but differences in being more experiential, being more feedback, more reviews, more learning and sense of feeling held. I'm guessing that these are things you'd want to bring forward as well into your own supervision. You know, particularly thinking about that kind of experiential bit and that viewing of tape and that really close focus on the cases throughout. Yeah, and lots of people also say group supervision and particularly focusing on the same disorder. So maybe some ideas there about what you can do in your own services around disorder specific supervision, perhaps. More structure, more reflection, more kind of focus on complexity. That's really helpful. Yeah, and this is the Young's just saying IAPT supervision tends to get overtaken by the IAPT context, case management risk, more sessions, etc., which is all very important stuff and needs to be dealt with in supervision. You need support with that, but it can sometimes be at the cost of that real clinical skills focus. You keep the feedback coming, so it'll be interesting for everyone to see that. Hopefully, we really hope, certainly the feedback we've had as supervisors, that people have really appreciated the supervision, which is great. But we're going to move on now just to talk a little bit about thinking about cases and supervision and with the supervisees. So just a little reminder from day 2 that we kind of surveyed our experts, and our experts said that a good training case for PTSD, so if you're looking for training cases, particularly for your trainees, but also for people who are just kind of maybe a bit less sure of their PTSD skills, is that first of all, well, for everyone, if you're going to apply the PTSD protocols, they've got to meet PTSD criteria. So that's diagnostically, you want to be working with the right thing. It should be the main problem, not too much comorbidity, ideally. Again, we know the context. Ideally, a low number of re-experienced traumatic events. These early cases, 1 to 3, ideally adult trauma, ideally not complex, low risk, and they've got some kind of support network in place. So you're not holding that, your relationship is not the only kind of secure base that individuals have. Also, actually, interestingly, people said not too mild, because actually then sometimes it's quite hard to really kind of explore the techniques appropriately with your client. Obviously, you don't want to give them more intervention than they need. That would be unethical as well. So ideally, you've got something like proper PTSD that you're working with, and that they'll consent to recording and filling in measures and committing to attend, etc. So we put the, so if you've just gone to the next slide, we've put this reminder of these kind of criteria, and also some really good questions to work through with your supervisees in your pack today. So you've got a sheet with that, and just these questions effectively mirror the things we've just said about what makes a good training case. A really nice list just for you to have to work through potentially with your supervisees when you're trying to identify a case. The next slide, please. So we are, as I've said, we're aware there's a lot of complexity in IAPT, and even when we have theoretically straightforward cases, it's not just a matter of changing by numbers. The originally applying a protocol, it's often a criticism people level at IAPT, that we're all just trying to just do 1, 2, 3 and can't deviate off that. That's not, we know that's not the case clinically. That's not what we're invested in doing, because every case requires individual decision making. So how do we make those kinds of treatment decisions when there are multiple options, and without just retreating to being really rigid or drifting massively from the evidence base and becoming, just not having a compass in terms of where you're going? Next slide, please. So supervision is clearly a really important part of this, and it's in this territory of meta-competencies, this last column on the slide here. Mastering meta-competency is defined by Roth and Pilling, as defined by Roth and Pilling, is probably also the work of a whole career in CBT. It's not something that any one of us has got nailed, but they're also the skills we're attempting to provide opportunities for our trainees to develop, or our sort of new to PTSD work therapists, to their application of trauma-focused cognitive therapy. Next slide, please. So meta-competencies are these higher order competencies that focus on the ability to implement models in a manner that's flexible and tailored to the needs of the individual client, and also procedural rules for applying therapy in a theoretically coherent but appropriately adapted way. So finding that middle road between being rigid and painting by numbers, and actually adapting to the client in front of you without losing your fidelity. So asking this of your trainees is a big task, and learning the model thoroughly, applying it in practice, and dealing with complex presentations at the same time is tough. However, to use an analogy, if anyone here ever, like me, had a fantasy of learning to play jazz really well, think the ship sailed, but that's been the fantasy. When you hear a brilliant jazz pianist, for example, improvise, it's something that just sounds amazing. It's easy to think it's something you've either got or you haven't. However, I am learning from my children, my middle son, my 11-year-old in particular, that this isn't the case, because actually his piano teacher is teaching him to improvise. So like me, when I learned the piano badly many years ago, he practices his pieces over and over. He pays attention to the music until he's committed to memory, muscle memory, the notes and the order of that. But unlike me, when he improvises, the notes aren't in front of him. So if I were to attempt that, a pretty unmelodic cacophony of noise would emerge. But the difference is he's learned and then practiced some basic principles and guidelines. So jazz scales, for example, the notes that he'll incorporate and the principles of repeating rhythms. So that structure, his improvisations, they provide structure for something that just sounds like it's being made up on the spot. So each time he plays, the actual sequence of notes may be a bit different. The dynamics may change, but the principles that he's learned hold the structure. And he's getting better at it all the time, and the more he plays. So next slide, please. Applying that to cognitive therapy for PTSD, there are a couple of really useful questions that we can ask in supervision and of ourselves when we're doing our own supervision. So thanks to Martha Nichols for this brilliant acronym, which is not meant to offend, but it does help stick. WTF. It's not what you're thinking. So we're going to click on a couple of times. So this applies to two questions. First of all, what's the formulation? And secondly, what's the function? So we're going to next slide, please, Annie. So firstly, and you may have noticed this in your own course supervision, our cognitive therapy for PTSD needs to be formulation-based rather than a formula-based therapy. So we keep coming back to the clients presenting problems and how the trauma-focused cognitive therapy underpinning model makes sense of that. So we're asking all the time, which are the key targets of trauma-focused therapy we're working on? You remember back to Anke and David's model, kind of the idea that we've got are we working on the nature of the trauma memory? Are we working on elaborating, joining up, contextualizing the memory and the triggers as part of that? Are we working on the negative appraisals of either at the time of the trauma or post-trauma? Whether that's by kind of the trauma itself or subsequent reactions to the trauma, or are we working on the strategies intended to control the threat? And obviously you're not often working on more than one of those at the time, but where is the key focus of the next step that you're taking? Next slide, please. Secondly, we need to be thinking consistently about the function of the intervention or technique we're applying. So we're not just rigidly applying one technique after another. We're thinking, do the techniques I propose to use next match the formulation target, particular presenting issues that we're working on at this stage in therapy? So does my supervision or my supervisee, my supervisee's application of these functions facilitate elaboration of memory? If we're looking at the memory cognitive reappraisal, if we're looking at those excessively negative appraisals, or is it reversing these strategies that were intended to control threat that have that kind of paradoxical effect of keeping the memory unelaborated and preventing the reappraisal? Next slide, please. So here are some examples just to ground that and what that might actually look like. That's the theory. What does that actually look like? So it might be, for example, that you're working with someone, or your supervisor is working with someone that has comorbid depression, and that might have occurred as a consequence of PTSD, but it's still very, very significant and very, very pervasive in terms of the presentation and the work they're doing. So you may be incorporating elements of behavioural activation into the more PTSD focused reclaiming your life, but remaining focused on the memory work as key to enabling the remission of depression. depression. So the depression might be, getting in the way of doing some of the reclaiming in life. So you are kind of actively thinking about how behavioural activation might facilitate that. But actually your target, your focus is still on the memory processing so that they can actually engage more widely in what they're doing in their life, and the reclaiming of their life can help facilitate the elaboration of the memory as well. Or it might be that you're, thank you. It might be that you are formulating specific fears that the client has about reliving, and we know from research done previously that if people don't ask about people's fears about reliving, that's when you tend to get dropouts in therapy. It's really important to ask your clients. In my experience, absolutely no client has sat in front of me and said, what I really want to do today is relive the memory of my trauma. However, when there are more and less significant blocks to that, often people just need a bit of encouragement. They need to understand the rationale for doing it. But sometimes people have other major blocks to that, which we've talked about on the other days, like panic disorder and worried about, for example, they're going to have panic attacks when they do that. So you might be doing a bit of formulation around that and psychoeducation so that they can do the reliving without abandoning the key elements of the PTSD treatment. Or it might be that instead of kind of sort of slavishly following paint by numbers, what I'm going to do is I'm going to do the reliving first, because that's what the model says we do first, and then we move on to the updating, and then we move. Actually, you might find in the early stages of understanding the trauma, there's a really quick win hotspot that you can update and work with. What do I mean by quick win? I mean that actually it's very clear that this is a hotspot that has a very simple piece of reappraisal that you can insert back into the memory, actually really moves the client forward because gives them huge hope. They see a real shift and change in their symptoms and how they can view it, and actually it really provides a great platform for the rest of the work, because actually they know that they're kind of bought in at this point. They know that actually, although you can't change the past, these kind of quick interventions to update an appraisal that's very clear, easily contradicted, actually really makes a significant difference in how they feel. And that's, provided it obviously feel the alternatives have been clearly identified, are believable and fully articulated by the individual. Or it might be using a site visit early in therapy to enhance reliving, because we usually do site visits towards the end. If you're painting by numbers again, you say, well, that comes at the end of treatment, don't do that now. But actually, you may need to do that near the beginning of the treatment in order to kind of enhance reliving, to discover details that are not clearly there for the client. Maybe there's kind of perceptual distortions which can be corrected very early on by doing the reliving at the site early on, or just piecing together, kind of doing a bit of detective work around what's there, what was really there at the time. Or being brave enough to retrace your steps when it becomes clear that a piece of hotspot updating missed the mark in terms of meaning. So that's what's really hard often, because when we're kind of, particularly when we're learning, you've got to do this and I've got to do that and I've got to do the next thing, and I can't possibly do a bit of hotspot updating and then go back to reliving. I couldn't possibly have done a site visit and then I need to actually go back and realise that, do you know what, we haven't got, to use one of Carrie Young's analogies, that we haven't really got understood the lock in that piece of memory, the thing that's keeping that appraisal going, and we really need to kind of dig around a little bit more about what really was bad about that at the time. It seemed like we got it, it seemed like it was obvious, but actually we've done the updating and it's not biting, so we need to go backwards. Actually, we need to kind of find a bit more detail, and that might include things like site visits or other techniques to gather that information. Another one which I haven't put here, I thought I'd added on, but I haven't. It's just a reminder by actually reading Anka and Hannah's excellent paper on moral injury recently and applying some of that with one of my clients. And I know they talked about this also in the piece on shame and guilt recently. So thinking about sometimes when you've got shame and guilt with a client, and actually you think, right, the next thing to do is to relive this memory or this part of this memory, and actually the shame and guilt are not going to change because of the reliving. It's not something they're going to habituate to or emotionally process without first understanding some of the context around that. So sometimes it can work really well with, I'm thinking about a client I've been working with at the Ministry of Defence who as many people do, had some real sort of shame around some actions that they took during a combat situation, and really was carrying a huge amount of guilt and shame around that. And actually reliving that wouldn't have helped, but what did help was going back to understand the context of the time, and totally changed his perspective on what happened. And in the end, we didn't even need to do the reliving, which was fortunate because there are about 20 different traumas, but actually, really that's what made the difference. So it's thinking about always what's the function, what's the formulation, not just sort of robotically applying the next step in the therapy. So next slide, please. So we just wanted to leave you with this slide, which thanks to Nick Gray, I think he developed this slide particularly for thinking about supervision, which you'll be familiar with this learning cycle. It's the call learning cycle, which is kind of also used in things like CTSR, and you'll probably use this in terms of your reflective practice when you've been training or thinking about that as a clinician. But this applies that reflective cycle specifically to supervision. And it's a really lovely tool, I think, to have when you as a supervisor are thinking about preparing for supervision, or where your supervisees are at in supervision, or even just have beside you in supervision when you can, what do we do next? What's the next helpful thing to do? And you can, in a sense, you can start at any point in this cycle, because that's sometimes things you just thrown in at a part of it, but you're thinking about, is it helpfully here a kind of start and finish? So thinking about reflection on what has been done previously, thinking about supervision questions and goals and contracts and what's being brought to the session, then conceptualizing that, formulating it, thinking about it again, coming back to where are we working in the formulation? Where are we working in terms of cognitions or memory or etc.? How does that fit with the client's goals? Then planning, developing the formulation more, thinking about strategies, thinking about what the techniques we can use and what will be the functions of those techniques in the light of the formulation. Then practicing it, and some of you mentioned what was different about this supervision that you've had on this program has been really experiential aspects of it, and really making sure you do that role play and that listening to the tape, and which is really, hard sometimes to motivate ourselves to be creative like that, but actually really practicing it. And kind of even speaking out what you might say to the client in your next session, or the supervisor you might say, and then learning from that. So bringing that back either just after you've done the role play, or also after you've done it to the next supervision session, and thinking about what's been learned and what not only will help that client further, but also how that develops your skills more broadly as a clinician. So just a really nice kind of tool for you to have to take forward with you into supervision. And I think if we click on, that is us just a few acknowledgements there for some of the slides to Nick Brown and Adrian Whittington. Their excellent book, which I recommend to you, Mastering Meta Competency in Clinical Practice. And I think that's us.
Thank you, Rachel. I can't see any questions in the chat now, so please use the chat to ask any questions or points for discussion, raise points for discussion. What we can also do, we had planned a break now, so if we want, we have a 10-minute break, so you could we could start a break now, and then if questions pop into your mind during the break, to pop them into the chat afterwards, and we take them up then.
It's time to get a cold towel and compress on your heads. And
yeah, that's right.
Fan yourselves, shut the curtains.
Yeah, usually we set a time for coffee, but I don't know whether that's the right thing. Maybe iced water or something. So let's meet again at 10:25. Yeah. Welcome back, everybody. I now will hand over to Shina Lines, who's talking about PTSD competence and how to assess it and how to train people to stick to competence. Shina, all yours.
Thank you, Anka, and hi everybody. So so this is a focus on therapist competence, excuse me, and PTSD competence in particular. I think as part of this training, you've been asked to submit a therapy session. Some of you may have already submitted one, some of you may just be at the point of thinking about which one that you would like to submit. So this is just to kind of help you get a bit familiar with the scale and thinking about which session to submit and how to go about rating it. And I guess it's just really important to say that this is to encourage self-reflection and learning into our own therapy, which we try to do throughout our therapy careers, really. So I'm going to whiz through some PowerPoint initially, and then we're going to move on quite quickly to observing some role plays, doing some ratings together, thinking about what sort of feedback we might give to each other on these clips. As Rachel's already highlighted, just thinking about competence in relation to the Ross and Pilling framework, thinking about what actually is the makeup of competence, adherence, is it carried out as intended, is it delivered skillfully, thinking about the right skill at the right time, and behind all this, obviously, we're thinking about our patients. So we're always thinking about best practice for patients. Again, we have the generic, basic. What we're really focusing on today is the specific therapy skills, and we're looking at the PTSD protocol. A lot of you are probably very aware of the CTSR through working in IAPT. So we have the CTS from Young and Beck, which was actually developed in the 80s for depression trials, and the CTSR, which is the adapted UK version. So they're both widely used in CBT research and training. Both had a lot of analysis of psychometric properties and seem to be valid, reliable, and usable, but there's also criticism. So if you're interested, the Fairbairn and Cooper and the Muse and McManus papers are quite nice discussion papers on these scales, and also just on assessing competence, actually. And then the Kazantzis 2018 paper does a nice evaluation of the CTS versus the CTSR, and actually found them to be equivalent measures, both appropriate to use across research and training studies. What we also know is that using these scales improves with training, hence why we're doing this section on training. And it also improves with kind of working with teams and becoming familiar with the scale as a team and rating as a team. So moving on from if we think about the fact that the CTS, the CTSR were developed for depression, developed for generic therapy, and what we also know is that NICE guidance recommends anxiety disorder specific protocols. So the idea was about then developing anxiety disorder specific rating scales, which talk much more to the specific protocol. And what's been developed so far is the social anxiety specific rating scale, and also one for panic disorder. And these have both been had research done on them with high inter-rater and internal consistency, particularly for the social anxiety scale. And for the panic disorder scale, again, there's a study that compared the panic scale with the generic CTSR and actually found that the panic scale captures panic specific competency much more specifically than the generic CTSR. So it's just a little bit of background around how these scales have evolved, going back to the original 1980s CTS. The idea around all of this is also, again, thinking about patient outcome. So there's some kind of hypothesis there that the better therapists we are, the better our patients will do. Again, if we look at the evidence for this, there's been research done in depression, so there's found to be a modest significant relationship in depression. In CBT training, there was found no general relationship was found, but there was a trend for reliable improvement and a small relationship in depression. These are all studies that you can go and have a look at. But with the anxiety disorder specific scales, again, the evidence is stronger. So there's a stronger association for the social scale, that was in relation to the Liebowitz. And then for the panic scale, there was a stronger association with panic beliefs and panic-related disability. In that study, there was no relationship with the generic CTSR. So evolving from this, we actually started it a long time ago now, didn't we? But developed a PTSD rating scale. The psychometric validation for this is in process. Hannah, who's here with us or was here with us, she used it in a PTSD training study and found that it actually is able to assess training. So people were significantly more competent in PTSD post-training. So she did pre and post ratings, and that was maintained at follow-up. It's also been used to assess PTSD trial therapists at Oxcadat. And there's a study underway that's looking at it in relation to the CTSR. So again, another comparison study, which is also beginning to show high internal consistency and inter-rater reliability. So with all these scales, we really want to test, are they actually testing what we want them to look at? Some of the difficulties with this, of course, is how do you assess skillfulness or competence? Obviously, with all of us, our competence is developed over our career. It also develops across problems. So we're also feel that we're much more confident with some disorders than with others. It also varies across sessions. We all have sessions where we think that's terrible and sessions where we might think, well, that actually was quite effective. But it's also just thinking about how that helps if we think about our competence and look at our own competence, how we can prove the awareness of our own limits, awareness of the limits in therapy as well. And the other difficulty is often organisation and service barriers. So to use these scales, to think about our competence, to keep developing, we need time to do that, which often isn't a great asset of IAPT really. So it's just to say competence isn't an easy area to break down. So we see the PTSD scale, just to introduce the scale, and we're going to be doing some practice with it today. Like the other scales, it's broken down into two sections really. So the generic skills, which relate very much to the original CTS and CTSR. And then we have the disorders specific competencies. So I think the beauty of these disorder specific scales is they relate very closely to the protocol and to the model. So it's really useful not to use it to inform the therapy that we're doing. So it's quite nice. It's a very specific check and balance around what did we actually cover in therapy today. I'm not going to go through them all individually, but you can see how it just covers each area of the PTSD cognitive model. The other important aspect of this scale is there is NA attached to the items as well. So we wouldn't expect you to be covering every item in every session. It may be you're having a session working on appraisals, for example, of the trauma, pre-post or during. So you're very much focusing on item 14. We would actually kind of have 10, 11 and 12 in each session in some way. So there's some kind of PTSD model guiding, informing the session and reclaiming your life we like to have as an ongoing item. And then item 16 comes back to the meta competences that Rachel was discussing before. So is this an appropriate intervention for this session? So we're going to be looking in today's session on item 13, working on the trauma memory, which is clearly one of the key items in the work that we're doing. Hopefully you've all got to hand both the scale and the item 13, so that you can, well, really item 13 is the one to have while we're doing this work today. A key aspect of using these skills is actually familiarizing yourselves with them as well. So really becoming familiar with them and the content of them, which takes time. Each of the items is rated on the Likert scale, 0 to 7, very similar to the CTSR, from 0 to 6. And really, if you're thinking about competence, you're thinking of 3 and above. But these are the kind of labels that you're looking at: satisfactory, satisfactory, good, very good, excellent. One of the other top tips is to really use the overall descriptor at the beginning of the item, because that gives the overall gestalt of what you're looking for in that item. And then just think about, is this satisfactory, good, very good, excellent? So there are pointers within the different items for thinking about where to mark it. I think it's also where actually discussing this and getting a feel for the scale is important when we initially start to do some rating. So really asking you to do some self-ratings and self-reflections. There's a scoring sheet that goes with that. Your supervisor will be rating it as well, giving you some feedback. On the scale, there's also an overall rating and there's a rating of patient difficulty. What I think is particularly important with these, both for myself and for other people, is just reflecting on what I did well, what went well, what I might have done differently. So I'm much more cued into the feedback I get or the feedback I give and these overall summary than the actual ratings. Top tips, as I've said already, just to familiarize yourself with the scale, particularly part 2, which is a disorder specific area. See this as an opportunity for self-reflection, feedback and learning. Don't wait for the perfect session. So really waste hours trying to decide which session. Hand in a session which is just a typical session of the work that you do, and then you can get feedback on that. Most CBT sessions should tick enough of the items. So as I said, there'll be some NAs, which is fine. When rating, read the key features, have the item descriptors in mind. Try to mark objectively related to these. So again, maybe try and think about you're rating someone else. It can be very hard. We all hate looking at ourselves and listening to ourselves, basically, and that never seems to go away, no matter how often you do it. Submit an active session. So it's really helpful to see some active memory work or some in-session experimenting. So we can really see an active session which is helping to move the patient along. And also really to see this as a beginning and not an end. So the idea is just to enhance the idea of practice and discussion and taking it to supervision and then sharing it as dilemmas that we can work on together. And the other thing is to keep feedback succinct. So what is key? Sometimes there might be 2 or 3 things that if you change that, the whole session might actually change in itself, rather than detailed feedback across every single area. So we're going to share some clips with you now and ask you to, there's a couple of things. The first thing is, I think you were asked to bring some headphones with you or earphones. So I'd encourage you to put those on because part of the clip can get a little bit quiet. We're going to ask you to observe the clip. The first one is about 16 minutes in length. While you're watching it, just have the scale beside you, have a look at it while you're listening to and watching the clip. Sometimes it's helpful just to write a few notes down, a few things that you liked. Sometimes you might get some top tips of something that someone says, and maybe just write a few things down that you thought could be done differently. So do it as you go along. We're going to ask you then to do an individual rating, which you'll then take into a group. So we're putting you into your supervision groups. You're going to have about 10 to 15 minutes to discuss it, come back as a group, with an overall rating. So one person to put the agreed rating in the chat and just think about one thing that you liked, one thing that you did well. So for now, while you're watching it, just think about scale, think about writing down things that you like, things you think you might think someone could do differently, and then bring it back. So this is actually a role play by Kerry, who you may already have met in the training. No, let me just check the volume.
Okay, are you ready then to move on to talking about this hotspot?
Okay, yes.
So do you remember why we need to try and explore it and update it?
You said, didn't you, last week?
Yeah. Would it help if I just reminded
please.
you? Yes. Right. So, you know, as I said last week, everyone who has PTSD, when we go back and go through the trauma, then we find these worst moments, these peaks of emotion, and they're the parts that come back as intrusive memories and nightmares and things. And so what we have to do is we have to find some way of kind of reducing the emotion in those worst moments. And the problem with these peaks of emotion is they're like frozen in time, aren't they? You think and feel exactly what you thought and felt at the time, with the same strength of emotion. So what we have to do is we have to kind of go back to those moments and work out how to update them with what we now know, and update the meanings that we've taken from them as well with what we now know.
Okay.
And the update's a bit like a key. And you know, if you're trying to unlock a lock, the key needs to match the lock really well. The wrong key is not going to work. So to make sure that our key is as good as possible, we need to really understand the lock. Yeah,
that makes sense. Yeah.
So I'm going to get you to tell me a lot about that moment, the first worst moment, so that we really understand what's in there, and then you and I will sit down and puzzle out what the update should be. Yeah.
Okay.
Yeah. So what I'm going to ask you to do is just bring it back to mind again. But before I do that, is there anything you want to ask me about that?
No.
No.
It makes sense. I don't want to do it,
No,
but it makes sense.
Hopefully, this is the beginning of the end. We're going to work out today how to update it, and we'll have a go at updating it.
Okay.
Yeah? So it'd be just like we did with the reliving last week. So if you close your eyes and bring it back to mind, and then tell me what you can see and hear and so on, and then I'll ask you the same questions like I did last time. What are you thinking? What are you feeling? And again, just don't turn and talk to me, just carry on and answer me with, as you describe what's there. And once we've got a really good idea of what's in that hotspot, I'll get you to open your eyes, and then we'll work out how to update it. Yeah?
Okay.
And remember that I am here with you, and you can stop whenever you want to.
Okay.
Yeah?
Okay.
You ready?
Yes.
All right. Do you want to close your eyes then and tell me where you are and what's happening?
Okay. So I'm lying on the hospital bed, and I've been there a long time, and the midwife is a bit worried, so she's just checking my tummy to try and find the baby's heartbeat.
What's happening?
She takes a really long time, and I don't think she can find it, and she looks really worried. Yeah, she's just looking really worried.
Nash, you're lying there and you see her face. How are you feeling?
Really scared, really scared.
What's running through your mind that's making you feel scared?
That she can't find my baby's heartbeat. There's something wrong with her heartbeat.
So you're feeling scared and you're thinking there's something wrong with her heartbeat. Are you feeling anything else in that moment? Any other emotions?
it just makes me want to cry. I could just feel really sad.
Yeah. What's making you feel sad? Do you think what's running through your mind that's making you feel sad?
I just think my baby's died.
Terrible thought to have. So you're thinking she's died.
Mm.
It's making you feel sad. When you think she's died, what does that mean to you?
That I won't ever be a mother.
Yeah. It's a very sad thought, isn't it? And when you think she's died and that you won't ever be a mother, and it makes you feel sad, do you get any pictures in your mind?
I can see her, and I know she's dead.
Do you see an image of her dead?
Mm.
Oh.
Mm. I can see that.
It's horrific.
Mm.
Is there anything else in this moment? Anything else that you're thinking or feeling?
I think that's just it.
Okay. Do you want to open your eyes? Well done. Oh my goodness. Have a bit of water, yeah? It's a horrible, horrible moment. Okay.
Yeah.
You're here with me,
Mm.
remember? Yeah?
Yeah. Okay.
Well done.
Mm.
We needed to look into that to see what was there, yeah?
Hate it. That's what keeps coming back to me.
Okay.
Mm.
So now we know what's there,
Mm.
we can start to think about how to update it, yeah?
Okay. Yeah.
Just a couple of questions about that. When it was in your mind, how distressed did it make you feel out of 100?
Just 100.
Yeah.
100. Yeah.
And how nowness, the nowness of it, you know, how real did it feel when it was in your mind out of 100?
When I was just describing it
Yeah.
to you as 100%, I
Oh.
could
Yeah, when you were
see myself there.
moment.
Mm.
So we've got two sort of main emotions that are happening. Should we just, do you mind just writing them into this chart?
Mhm.
So we know what the moment is. Do you just want to write in how it's making you feel? So the first thing was it was making you feel scared,
Scared,
wasn't it? Yeah. And then it was also making you feel sad. wasn't it? Yeah.
I just felt overwhelmed with sadness.
I can see it flash right across you. Yeah.
Mm.
Well, I'm not surprised. And so there we're seeing, what are you thinking that's making you feel scared? You said it was something's wrong.
Yeah.
Baby's
That's-
heart.
yeah. So should I just say what something's wrong?
Yeah.
Yeah. Okay.
And then what was making you feel sad was this thought about that you wouldn't.
I wouldn't be a mum, and yeah.
And that horrible image of her dead. Okay. Do you want to just write in, I don't know, whatever you feel comfortable writing in then.
Mm. So I just write my baby's died.
Yeah.
Okay.
Okay, lovely. All right. So that's our lock. Yeah. We need to
Okay.
think about how to update it. Yeah.
Mm.
So thinking about, looking at that now, what do you think if you'd known it then and believed it? So I don't know, somehow I'd managed to time travel back and tell you,
Mm.
and you believed me, what would have made you feel less scared and less sad? Let's start with less scared.
If I'd known that that her heartbeat was okay actually.
Yeah.
I mean, it had dipped. They were worried because it was dipping, and it did get quite weak, but it was okay. They got her out in
Should we
time.
write that down then? What I know now? Yeah, on that one, yeah. Lovely.
So just say my baby's heart.
Whatever you like, yeah,
Okay.
something. What would you like to say, Mike?
My baby's heart dipped, but it was okay.
Yeah. So if I'd said that to you then would you believe me? Would you imagine?
Yeah.
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 And then what about the sad part, the part where you're feeling sad and thinking your baby's dead? What, if you'd known it then, would have made you feel less sad?
That I am a mum now,
Yeah.
and that I've got my baby.
Yeah.
Yeah.
Yeah. Yeah.
So I write that down.
Yeah.
I mean,
And the other-
I like writing
Yeah,
that
it's
one.
nice to write it down. It's not- Certainly what we know about when, and lots of people do have a kind of a picture when they, particularly when they think someone's died, they often have a picture of it as well. That words don't communicate that well with pictures, mental images, and that they don't quite talk the same language. So the words are useful, but it might be good also to have a mental image that strengthens that bit of information, yeah? So that you can talk to your mental image from the past and say,
Okay.
you're wrong.
Okay.
So can you think of an image, a picture that you have in your mind of something that tells you, she's absolutely fine, she's alive and well?
So an image of her being alive and well.
Yeah.
Okay. I've got a really nice photo of me holding her.
Oh yeah.
Yeah.
Okay, that sounds good, doesn't it? So you could, if you imagined that, and you know, that would help you to know and communicate the other image and say, yeah.
Yes.
Okay. All right. All right. So what we're going to do then is I'm going to get you one last time to bring to mind that moment, just as we just did, and then I'll get you to tell me about how you're feeling in that moment, and about what you're thinking, and about that image, and then I'll simply say, what do you know now?
Okay.
Yeah? And then can you bring in this, still with your eyes shut, you know, my baby's heart dipped, but it's okay. And she's alive and well, and then
This image, yeah.
yeah.
Okay.
And we'll see if that helps. And what we'll do is we'll see if it makes you feel less scared and less sad. That's all we need. Yeah?
Okay.
Yeah? You ready?
Yes.
Okay, let's do it. So close your eyes then and tell me.
So go back to the worst bit again.
Right, bring in where you are and what's happening.
Okay, so I'm lying on the hospital bed and the midwife is trying to find her heartbeat and she can't, and I can see her face just looking a bit panicked.
And how are you feeling?
Terrified, just terrified.
And what's running through your mind?
They can't find her heartbeat.
How else are you feeling?
My baby's died. I'm just really sad.
Can you see that image? Okay, and what do you know now? Tell me what you know now.
My baby's heart's okay.
She's okay. Can you bring to mind that image of her now?
I've still got the bad image.
Maybe just try putting your arms as you're holding her. in the
Okay.
image, yeah?
Yes, I can.
Can you feel her there?
I'll just.
Yeah?
So she's here in my arms.
Yeah? How does that feel?
I can feel the weight of her. And,
What's she doing?
she's smiling at me. Yeah.
But she's smiling at you, so you know what you know. She's okay.
Yeah.
Are you there on your own? Is Richard there?
Yeah, no, he's here in the photo.
Yeah.
I can feel his hand
Good
here.
feeling there.
And he's looking at her too, really lovingly.
So as you're there with her in your arms, you can feel her, you can feel Richard. She's smiling. How do you feel? Do you feel scared?
No.
Do you feel sad?
No, not at all. I feel quite happy.
Do you need anything else to feel okay?
No, I like it when she looks at me. I can, if I'm looking at her, I feel okay.
So you don't need anything else?
No. I feel quite calm now.
Okay, do you want to open your eyes?
I liked it. I like holding her like that.
I did it too.
That made the difference. I found it really hard.
Yeah.
But
If you do that, when you're trying to imagine something, if you put your body in that position, it helps, yeah.
it made a big difference.
So that looked to me as if that worked, yeah? If we wanted to reduce your sadness and your fear, it looked like we did.
In that moment, it took away that
Yeah.
and brought back the happy thoughts and images. Yeah.
Sounds good then. Think we've done it?
Okay, so let's go back to this. So first of all, we have to thank Kerry for that fabulous role play. So what we'd like you to do is just now jot down your own rating on that clip. Hopefully you took some notes as you went along, writing down things that you liked, things that you might do differently. And then we're going to put you into breakout rooms in your supervision groups. What we'd like you to do is just have a discussion around the clip, come to a consensus about what number you would give it as a rating, and to think about reporting back one thing that you liked, that she did well, one thing that could be improved, and just to sort of allocate one person to do that. So when you come back, we're going to hopefully just put the score in the chat first of all. We'll have a look at those, and then we'll have a look at some of the feedback that you thought she did well, anything that could be improved. Any questions about that before we put you into groups? You have the item beside you to discuss as well.
Yeah, I put that back in the chat, and I can also share the slide with the breakout rooms again. A bit was cut off last time, so I can, if you want me to do that. Are we rating all items? No, just a specific.
Just item 13.
Just item 13.
Yeah.
Mm-hmm.
So just all come back with one rating, and you'll probably have lots of things that you liked and a few things that you thought you could do differently. But just see if you can pick one of them so that we can get it across all the groups, get a bit of variety, but not be overwhelmed with them. We're going to give you 12 minutes to do that. So we'll come back in 12 minutes. We'll call you back in 12 minutes and then have a discussion about it. To come back then, so can the allocated person, first of all, just put the rating that you all agreed on into chat? Let's just see. Okay, we scored a 5. I'll come back to the feedback shortly. So just ratings for now: 5, 4.5, 4.5, 5, 4, 4. We were a bit. Oh, what's going on? We were a bit split in our group. Some people said 4, some 5. Yeah. So this seems, interestingly, there seems to be consensus, doesn't there? 4, 4.55. So everyone's nicely in the same ballpark, which is great. The first time we did this, we actually had a group of supervisors, and they also gave it a 5, just to give that as a bit of a benchmark. So What about feedback? First of all, what were the things that you thought she did well? So if you're thinking about the feedback you have to give to your supervisee, what are some of the key things that you would like to encourage her to keep doing, or things that you liked? I know there was one back up here. The use of the lock and key analogy was great. It was, wasn't it? But the first time I saw this clip, I wrote that one down to use in future. Okay, we'll come back to negatives later. Updating using posture and imagery. Yeah, that was so lovely, wasn't it? You can really see how that cuts into emotion as well, how her, just in that moment, her emotion changed. Listing emotions, appraisals and hotspots, updating these. Absolutely. I just thought what was fabulous was just how much emotion was in the room, which is what we really want, isn't it? Introduce the rationale to trauma work. Nice and reasons why nicely. Sorry, you want a therapist. Listed image of trauma and emotion. Yeah. So again, we seem to have a consensus on what we liked and what she did well in that clip. So what about things that she might have done differently? I know that first group said that she, I'll go back to it again. I think you struggle to find negatives. Maybe could have elicited further key learning from the reliving. Sure. So there's a bit more time at the end to unpack, which I'm sure Kerry would have done this time. Okay, other things you could have done differently. Ask for other senses, sound, smell. Ask more about predictions for sure. Collaboration, it's an interesting one. Checking in with clients' understanding. Does anybody want to pick up on the collaboration? What was it that you thought she might have done differently there?
Yeah, sorry, that was me.
Yeah.
Oh, and I agree. We just kind of said bits at the start, maybe checking in with the rationale. She said, like, I don't want to do this.
Yeah.
And we just kind of checked in, but we said there's quite a hard balance between going too much into that and going either way. So
yeah,
like
sure. That. No, that's nice. Yes, that's a nice point, really. Thank you. And then improved a bit more feedback at some points. The client was being led. The pacing of the clip, although I appreciate it was a role play, wasn't given full marks as the client was not too complicated or resistant. Sure. But we often in these role plays, we want to kind of demonstrate it working. Fabulous. Anything anyone wants to add to that verbally, rather than the chat as well? Anything anyone would like to share? Will I just bring my PowerPoint up again? Sorry. So I'm just going to share the supervisors' feedback. So again, this was a group of supervisors. They said there were some really nice aspects to this session. Well done. Nice use of a metaphor for the hotspot update, embedded within a clear and understood rationale, clear collaborative process with feelings, thoughts, images, and meanings explored together. And then areas to improve. What they thought was just to check a bit more of a check on ratings. So the distress and nowness belief. So again, I guess she could have checked on those a bit more at the end to see how much the emotion had shifted, couldn't she? To check the impact at the end a bit more, which you've all picked up on as well, and a bit of a slower pace. So just slowing it down, which I'm sure in a proper session with an hour and a half, she would have done. Okay, so I'm going to move on. Any final questions or thoughts before we move on to the next clip?
just one question that came up in our when we were watching back in our feedback group. We were just wondering about the distress rating, taking it outside of the reliving, the stress and the nowness. Because most of us are like, oh, we do it while we're in there still to get it kind of focused, and we just wondered whether does it matter, or whether, you know.
Yeah, it's a very good question. I don't know what the others think, but I think it can matter. Sometimes if you try to take distress ratings during reliving, you can interfere with the processing. They almost have to stop and think, oh, how upset am I? Oh, I'm 100%. So I prefer to let them do the whole thing and ask about distress afterwards. And then I might say, what were the worst parts? What were the most distressing parts? So I can then gauge it across the hotspot as well. But I find doing it during, I try not to interfere as much as I can while they're actually in reliving, because it can just cut into emotion. I don't know if Anka or anyone else has any thoughts on that.
Yeah, I agree that when we are working on hotspots, then it is likely to interfere with them accessing all the emotions and all the meanings. I think we initially in the teaching emphasized taking regular ratings in reliving, but this is when we're kind of looking, like searching for hotspots still. So you are, as a therapist, not quite sure whether if somebody is like going very silent, for instance, and whether that's because they are distressed or dissociating. So then it's useful to gauge their level of engagement with the memory. But once we go into the hotspots, I think I agree with Sheena that it's likely to pull them out and we lose important emotional impact.
Great, thank you, Anka. Okay, so we're going to move on to the second clip now. This is shorter, this is about 8 minutes in length. So again, have your headphones on, have item 13, so it's just item 13 that we're looking at here.
Okay, so are you ready now to try and explore and update this hotspot? Yeah?
Give it a go, yeah.
Well done. So we'll just do what we did last time with reliving. I'll just get you to close your eyes and then, tell me about what you can see and hear and so on.
Okay.
And just sort of try and, see what it is that's making it a hotspot, what's making it so bad. Yeah?
Okay.
Yeah?
Mm.
And then we'll have a chat about it and think about how to update it. Yeah? And then we'll insert a bit later on in the session. Okay?
Okay.
Lovely. All right, so you ready?
Mm-hmm.
All right. So just close your eyes then, like we did before, and just tell me where you are and what's happening.
I'm in the flat,
Mm-hmm.
and my neighbour has just texted telling me to get out.
So you're in the flat and your neighbour has just texted telling you to get out.
Mm.
Okay. What happens next?
I go to the front door.
Mm-hmm. So you go to the front door. Mm-hmm. How are you feeling?
Terrified.
Mm-hmm.
Yeah.
And who else is in the room?
My children, my 2 children are there.
Okay. So your neighbour's just texted and you're going to the front door and you're feeling terrified. Okay. What time of day is it?
It's late, it's about, I don't know, it's 11, 12, yeah, close to midnight, I think.
What are you wearing?
Well, I'm in my dressing gown. I've got my pyjamas on and I've got a dressing gown on and slippers.
So you've got your pyjamas on and your slippers, it's late at night, and your friend's just texted, and you go to the door and the children are there. What happens next?
I open the door and it's just black and smoke.
So you open the door and it's just black and smoke. Okay. And how are you feeling?
really, really panicky, really scared.
You're feeling really scared. Yes, of course you are. Of course you are. And what are you thinking when you open the door?
We're not going to be able to get out. We can't get out. How are we going to get out?
How are we going to get out? So you open the door, it's all smoky and dark, and you think, how are we going to get out? Okay. All right. Open your eyes. Horrible.
Oh God. I hate going back there, yeah.
All right. So let's write that down on a chart, and then we can think about how to update it, and then we'll insert the update into the reliving later.
Okay.
Yeah.
Okay.
So so in this column, then, if we just sort of write down what the moment is.
I think it was opening the door when I opened the door.
Yeah. Okay. And then this comes about what you're feeling. So you said you felt terrified.
Yeah.
Really. Write that down. Lovely. And you said you were thinking, how are we going to get out?
Yeah.
So if you,
But how will we get out?
Yeah.
Okay. Is that all right?
yeah, okay. And in this column, it's just about what was going on. So I suppose it was very smoky and dark, wasn't it? So
Yeah.
if you wrote that down, that's so lovely. Okay. So that's what's in that hotspot, and I mean, just need to think about how to update that hotspot really. With what if you'd known it then, would have made you feel better. So when you're at that moment when you're thinking, how will we get out? It's about what if you'd known it at that time somehow and believed it would have made you feel better. Like that you did get out. Yeah.
Yeah.
So what do you think at that moment?
Yeah, if I'd known we did get out, I think I'd feel a bit better.
Yeah.
Yeah.
Well, you did, didn't you?
Yeah.
So, yeah. Okay. Yeah.
Yeah.
So I mean, that's all we really need to do is just think about that moment, and then what we need to do is go back to the moment again, relive that moment again, and then insert an update. So the update, I did get out. We just insert that into the reliving, into the memory.
Okay.
Yeah. And hopefully that will work.
Okay.
Yeah.
And that then stops it flashing back and coming back.
Hopefully, yeah. Yeah. Yeah.
That sounds good. I'd like that.
Yeah. So do you wanna have a go with that?
Okay.
Yeah. So
Okay, I'm going to stop it there because I think that kind of covers the key aspects of it. So what we'd like you to do is to get back into your breakout rooms again and do the same as before. So just quickly do an individual rating on item 13 in your groups, have a consensus, have a discussion, come up with an agreed rating, and one thing well, one thing differently. And this time I'm going to give you 8 minutes to do this. Welcome back again. So can I invite people to once more put their agreed ratings into chat? .5. Two point five. So just the ratings for now would be helpful. 2, 2.5, 2. 2.52. Okay, so again, brilliant. There seems to be a consensus here, doesn't there? 2.5. So what do people think she did well? So we always want to balance feedback as much as we can. What did you manage to think about feeding back in terms of what she did well? Showed warmth, collaboration, got her to write, absolutely. What she did well, some structure, some rationale, moments of warmth. Yeah, the rationale was a little bit less clear, wasn't it? She was very good at summarizing, perhaps she's a bit much, summarized, useful questions, elaborating the hotspots and updating, more focused on eliciting emotions. So is that what she would have done differently? I see. Let's move on to what she would have done differently. What she could have done differently. So if there was one or two key things you'd want to say to this therapist, what would they be? What might help her in developing her skills? She didn't elicit the meaning of the hotspot, didn't encourage hope. So yes, a bit more exploration would have been helpful, wouldn't it? Slowing down, exploring. Identify key appraisals, simpler rationale, being more Socratic, taking time, understanding the function of the technique, a bit more work on the meaning, no rationale, repeating what she said, no appraisal, slow down, elaborate some ratings. So again, there's some consensus there about her needing to slow down, collaborate, use a rationale, and get to the meaning, which is what we're always wanting to do with hotspots. Didn't instill confidence. It was kind of very task focused, wasn't it? Very like, we've got to get on with this, let's do it, and this is how we're going to do it. And I don't know about any of you, but I've certainly seen sessions like this, and I've certainly rated sessions like this. So it's always good to have a think about the kind of feedback you might give. If I just move on to the, so again, this was the supervisors. The supervisors also rated it as a 2, just as that benchmark. The feedback they would have said was a competent start for a first reliving and update. Strengths, the memory was nicely activated. Thoughts and feelings are beginning to be identified. And there was a focus in on a hotspot with some updating. Areas to improve, more exploration, eliciting thoughts, feelings, meanings, let her tell her story, so sense of sit back and let her talk, more collaboration, inquisitive, Socratic, less interrupting, suggesting, and some idea of embedding the reliving and updating within a clear rationale. So absolutely repeats all the thoughts that you had as well. Finally, before we finish this section, I just wanted to do a final slide about competence and just thinking of it as dynamic and not static, that it's really lifelong learning and something that we're always working on throughout our therapy career. Thinking about Glenn Waller's work on therapist drift and how easy it is for us as experienced therapists to drift off into some new techniques or new ideas rather than sticking to what we know works. And in using these scales, it's just to encourage this idea of ongoing self-reflection, ongoing live review. So really bringing clips, looking at our own clips, rating them, discussing them, sharing ideas, ongoing self-assessment. We know we do a lot of this on training. We know a lot of it goes out the window once we start then working with therapists, which is a shame in my view. And also just to keep anxiety disorder specificity in mind. That's where we know the evidence is. Thank you very much. Anka?
Yes, thank you very much, Sina. That's good. I don't see any further questions in the chat at the moment. So maybe it would be time then to take our 10-minute break again, and just to remind you, if anything that you've seen or has raised question in your mind, or you would like to discuss with you, please put it in the chat and we come back to it at the end of the session. So can you put the supervisor improvement slide back for a moment, Sheena? Maybe, yeah, so. Okay, we can leave that up in the break, and then we'll meet again at 5 minutes to 12. Yeah, I see a few faces coming back here. That's difficult to know how many are back yet, but I guess we have said 10 minutes. So welcome back, and Emma Warnock-Parks will now talk about tips for supervision.
So hi everyone, welcome to this very hot day. I hope that you can't hear the fan, hopefully, that's sitting next to me. Does that sound okay? I'm really grateful you said that, because I'm in a very hot office right now, so I hope you're all staying cool. So let me share my screen here. Up my PowerPoint here. Okay, hopefully everybody can see that. Fine, okay, so in this section we're going to talk about top tips for supervision. Because I could probably talk about this all day, we pulled together a bit of a document that is in your handout pack, covering 10 top tips for supervision. So, you know, if you're getting some fresh air later over a coffee, you may want to peruse that, but we'll try and cover as much of it in this slot as we can. Okay, so much like cognitive therapy, really good supervision is all about getting into the details with people. We want to ultimately get into the head of the person who's being treated and get to the core of what the trauma means to them. And that really involves some detective work in supervision. And we know that the best detectives have access to really good detailed information. So it can be immensely valuable if supervisees bring lots of helpful things along to supervision with them, like their supervision records, like questionnaires along, bringing formulations, bringing bits of tape so that we can look at it together and really try and get into the patient's head, because obviously as a supervisor, you haven't got the patient in front of you, okay? But a common problem is that supervisors therapists often don't bring all of these things along with them to supervision. So it's really important that we think about what the barriers might be to that. And it can sometimes feel a bit threatening to bring your tape, to bring all this kind of detailed information along to supervision. So we really want to create a space in supervision that feels very supportive, that feels like a safe space to kind of really get into the detail of what's going on in the therapy. And what can help with that? I mean, you'll all know this from your own supervision, but ultimately we really want to create an environment where there's no such thing as a stupid question, that all questions are welcomed, where as supervisors we may be modelling imperfection possibly in our supervision. We've got some wonderful videos on the Oxford Resources site, as you've all seen, but they're scripted role plays, okay? So it can give people the impression that there's this perfect way of doing therapy, and actually supervisors can really help, I think, to model in role play that, you know, the realities can be a little different to that. There's no such thing as a perfect session. And then when it comes to kind of viewing video, we really want to welcome people to bring video in a way that feels non-threatening, and it can really help to do that, to encourage supervisees to look at the video very objectively, to focus on what's going well first and the strengths before we look at what we can build on, just like Sheena was covering with you just then, to really try and think about this as any other therapist. And why is that important? Well, most of us, when we see video of ourselves, may kind of show this kind of face. We cringe a little bit, don't we? I'm sure all of us here has had that experience of finding it quite hard to see ourselves on screen. Our inner critic tends to kick up. And so it can be really important to try and help the person, the supervisee, to really sort of watch themselves as they would any other therapist. And just in case it's helpful, I'm going to pop in the chat. I've put together a short sort of 2-minute video that you may want to share with supervisees before they watch video, perhaps watching it together in supervision, or send it out to some of your supervisees, which covers some key tips on how to turn off your inner therapist critic and watch the video much more objectively. It may even be something you might find useful yourself to look at. Okay. So as supervisors, it can be really helpful to keep in mind really common challenges that lots of supervisees have, okay? And I've put on this slide a few that we've spotted in our group, and also the supervisors have sort of fed back to us. And we're going to elaborate on these in this little part of the teaching today, but I'll just mention them briefly. So the first one is bringing the formulation and always having that at the heart of guiding the therapy. When we're learning a treatment, we're often focused on the kind of what do I need to do next rather than the why do I need to do it. So it's really important that the formulation is always at the center of the sessions. We want to model that in supervision. And linked to that is the use of questionnaires, and particularly really helpful process questionnaires that spot things like common cognitive themes and safety and behaviours and maintaining strategies. And that's often something that therapists aren't necessarily using very frequently in therapy or bringing to supervision. Okay, so something to kind of look out for when that's not happening, and I'll cover that in a moment. Reclaiming life is a really key intervention, key manoeuvre in cognitive therapy for PTSD, and it's something that we want to really do throughout treatment. It has a range of functions really. In addition to kind of lifting mood, it can really help with updating, it can address appraisals of permanent change. So it's a really key intervention. But what we often find is that supervisees maybe start that at the beginning and maybe forget to come back to it throughout therapy. So something to keep on the table always in therapy. So something to look out for in supervision if that's not happening. And then coming back to, as you saw in those lovely videos of Kerry earlier, the importance of unpacking hotspots, really kind of drilling down, getting to the core of the onion, if you like, is something that is often missed by therapists. There may be multiple meanings to a hotspot that really need unpacking. So really, really key as supervisors, we're keeping in mind whether we've got to all the meanings, if we unpacked all the meanings. And linked to that, as you saw with Kerry's lovely metaphor of the lock and key there, it's really key that, you know, we get the core of the meaning so we can bring in really linked, powerful updates. And to do that, we want to draw on a range of modalities. Again, as you saw, movement, senses, all those kind of things. And this is something that therapists sometimes don't draw on the full range of modalities to really help those powerful updates sink in. So something to be looking out for in supervision. And finally, a common kind of problem is getting out of the therapy chair. So when it comes to experiential exercises in therapy, like behavioural experiments, like site visits, those kinds of things, often what we're seeing is that therapists might suggest that the patient do something for the homework without doing it together first. So we'll talk a little bit about how we can help therapists with that in supervision. Okay. So over the years, I've had the kind of joy really of being in very specialist PTSD supervision, and often started coming into supervision with a feeling of overwhelm by the presenting problems that the person I'm working with has struggled with, a bit like this sort of tangled web on the side. And something happens in supervision to help make sense of that kind of web and move us towards recovery. And I spent many years thinking, well, what is it that's happening behind the scenes of supervision? What is going on in the heads of these expert cognitive therapists that are helping them make sense of this kind of tangled web that it felt like for me in supervision? And what I discovered by really studying my supervisors, always doing at the heart of supervision is hooking everything I'm telling them onto the cognitive model. So when I'm presenting all the details of a case, what's going on in my supervisor's head is always kind of hooking the information onto what are the core meanings for this person? What are the maintaining strategies? What are the maintaining safety behaviours? They're always keeping the Ellison-Clark model in mind and linking the information to that and helping me unpack it. And I would always hear in supervision, well, what is the worst meaning for this person? Have we got to the bottom of the worst meaning. Let's look together at the questionnaires and see if we've missed any meanings. The theme was always about getting to the core of the onion. And so I think it's really key that as supervisors, we are bringing the formulation in every week to supervision and keeping that always on the table. That involves quite a lot of detective work. Okay, we're really meaning detectives, if you like, in supervision, constantly hunting for new meanings. And a case example in supervision recently of this would be somebody, a supervisee, brought a case they'd worked with somebody who very sadly, as part of their trauma, had witnessed a man jump from the top of a car park and take his life. Okay, and they'd done some really good unpacking of one hotspot of one particular meaning that was linked to the emotion of sadness that the man had died and he'd left loved ones who were still suffering. They'd done some nice updating of that together. But when the supervisee brought this case, what we realised is this man was still re-experiencing this worst moment in flashbacks over the week. It hadn't kind of shifted for him. And it was a puzzle. So we needed to find whether there were any missing pieces here. And that needed some detailed detective work in supervision. So we kind of started to kind of explore what other hidden meanings there may be. Okay. And actually what we managed to find was that there were two other emotions and meanings that were really key in this hotspot. So two pieces of the puzzle that hadn't been found. One was that the man was also feeling very guilty, that he should have reached out to stop the person from jumping. Okay. The other was a strong feeling of shame linked to the meaning that they had turned away at the time when this person jumped, and that meant that they were weak. Okay. But the tricky thing for supervisors is that we just don't have immediate access to the patient to get these details. So where might we find these pieces of the puzzle? So I'd like you just to have a think now and pop in the chat or sort of speak up now in terms of, you know, what documents, what sources of information in supervision do you think would have helped us get to these meanings that were kind of hidden, that were missing in supervision? What would you need to ask the supervisee to bring, do you think, that might help you spot some of those things in supervision? Has anyone got any ideas? Brilliant, thank you, Gemma. So Gemma said questionnaires, Stephanie said, and as Manta said questionnaires as well. Brilliant. The PTCI, Amanda, excellent. So the PTCI here was really, really helpful. We were able to look at that and spot that guilt and shame were cognitive themes that were coming up, and to start to wonder, could those be themes that would be relevant in this hotspot? Any other ideas? Where else, what other information might have helped us you know, unpack this meaning or find more information about this? Any other ideas other than the questionnaires? Where else could we look? Tape of reliving. Thank you, Lena. Yes. Formulation, Lauren. Yeah, exactly. Listening to a tape. Yeah. So we had a little look at the tape together in supervision, and we could see when the person was reliving, he talked about turning away and actually looked down when he talked about this. And this was another kind of indicator. Could there be shame going on here, for example? Yeah, fantastic. Yeah, so we want to kind of get as much information as we can to do our detective work. And other sources of information could also potentially be the hotspot table. Tamara's added to the chat there, asking about appraisals after the trauma as well as during, so that's a really good point. And the hotspot table is also really helpful because often that unpacks the different emotions that people might be feeling at the time of a hotspot. And we want to use emotions as a guide. Sheila was talking about this earlier about using the emotion in the session, isn't it? Actually, if somebody is experiencing both sort of fear, shame and guilt, and actually you haven't got a meaning that connects to all of those, that's a puzzle. We want to get to the bottom of the puzzle. What pieces might be missing? There's a question in the chat, is that the table that Kerry was using in the video? I wasn't here for the first bit of the video, so I didn't see it, but I'll share a hotspots table shortly in the chat for you, if that's helpful. Okie dokie. So yeah, watching tape, looking at the memory narrative. So if in therapy there's actually a written narrative of the story, it can be really helpful to look in that for the details together. Use the emotions as a guide, watch tape together, get all of these detailed bits of information. And as you all picked up really quickly, the questionnaires are absolutely essential, both in therapy, but also in supervision. Really, without them, we often miss half the picture of what's going on. We can really miss key meanings. So they're absolutely essential as a guide in supervision. And I'd really recommend encouraging your supervisors to use the questionnaires, bringing them and looking at them together in supervision, doing, if you like, a bit of a deep dive together. And you can see in the image here on screen, this is a sort of role play video from the OxCADAT resources site of Leanne Jones being my therapist, and we're looking together at the PTCI, spotting some key meanings linked to shame here for me that were very relevant. But often what we find is that for different reasons, supervisees don't always bring questionnaires each week. They don't always give them out each week in therapy. And sometimes it might be worth exploring, are there particular therapist beliefs around that? A common one, for example, is that it's quite a burden for patients to fill in questionnaires. And often, you know, certainly this is my experience as well, earlier in my career, we haven't always had really in-depth training in using these questionnaires. We might not be familiar with them. It can feel a bit alien to use them. So actually you might want to encourage your supervisees perhaps to watch some of the videos on the OxCADAT resources site. In fact, I'll put a couple into the chat now. There's a really helpful one that Jennifer Wild does, really explaining the usefulness of each of the core process questionnaires in therapy. And so I'll just put the link to that there in. And there's another one here which really demonstrates Leanne Jones and I using the questionnaires in therapy together. And it can be helpful to either send supervisees away to watch those videos or watch a bit together in supervision. And I know my supervisees have always found it really helpful that when I look at questionnaires with them, I'm sharing what's going on in my head as a supervisor. What am I looking for when I'm looking at the questionnaires? Because I think that's a skill that as supervisors, when we're so used to using these measures, we develop over time, but actually our supervisees haven't got yet. So you kind of need to share what's going on in your internal world as a supervisor, I think. Okay. So moving on to helping updates really powerfully sink in to the hotspots, which was a bit of a theme really, wasn't it, in the videos of Kerry earlier. And you'll recall that lovely metaphor that Kerry used in the video of hotspots being a bit like a lock, really, and the updates being like a key that really needs to powerfully fit the lock to fully work and put the trauma memory in the past. It can be really helpful to share metaphors like that with supervisees. And I think someone mentioned this in the chat earlier, that often supervisees may not fully understand why we need to dig into the worst meanings of the hotspots and find updates that really link to those worst meanings and help them really sink in. So we really need to make sure that supervisees are really understanding the rationale, and those kind of metaphors can be brilliant to use in supervision. But once therapists really understand the rationale behind updating, they need to make sure that they're bringing in those updates in a very powerful way that's really going to help it sink in with the worst meaning. And as you saw in the video earlier, drawing on different modalities is absolutely key there. So using movement, using senses, using taste, all those kind of things, drawing on all those different things, using imagery were helpful to really bring the new meanings in. Now, supervisees sometimes don't feel particularly confident doing these things in therapy if they've not tried them before. So I would really encourage you to role play doing updating using different modalities in supervision. Okay, we've got lots of videos on the OxCADAT resources site that can be helpful to almost show a little bit of in supervision before you try a bit of role play. I think that's always a useful way to do it. And we've recently actually added a new video which shows the key steps of updating in therapy to the OxCADAT site. You can find that under the PTSD videos. If you scroll down to the updating section, it's called Key Steps of Updating. And what I might do is just show a few minutes of that video. I won't show the whole thing because it's about 12 minutes, but I'll show a few minutes. And there's a bit of repetition there because there's some similarities to what you were seeing in the video with Kerry earlier. But what it really does quite nicely is highlight what the key steps are, because ultimately as supervisors we want to always be thinking, you know, have my supervisees followed all these key steps? And these are some of the things that supervisees often struggle with. So for example, as Sheena was saying, really bringing on the emotion in the update before connecting it to the new information, really using those different modalities. So I'll show a few minutes of that video now, as it may be a useful one you may want to encourage your supervisees to watch.
In this video, we see a number of key steps involved in memory updating. Step 1. Unpacking the worst meanings. After Emma's traumatic birth, she continues to be distressed by an image of her son looking grey and lifeless after he was born. It can take some time to unpack the personal meanings of patients' worst moments. Helpful questions can include, what went through your mind at that moment? What did or does that mean to you? What was the worst that you thought could happen? What was the worst thing about that for you? And what made or makes this particularly upsetting for you? For Emma, seeing Hugo grey and lifeless meant that he had died and she felt horrified. As Emma's therapist prompts further, she finds that the meaning driving much of the sadness for Emma at the time was that she thought that even if he survived, he might have life-limiting brain damage and never live a meaningful life. Emma's therapist helps her to explore less threatening personal meanings. They discover that her son survived, and although he has some developmental delay, he can still do many meaningful things. These updates then need to be brought back into the trauma story. Step 2. Collaboratively identify ways to help updated information connect emotionally to the trauma memory. In cognitive therapy, a range of techniques are used to develop alternative perspectives that are less threatening. Here we see Emma and her therapist exploring ways that Hugo's life still has meaning, despite the developmental delay he experienced as a consequence of complications at his birth. However, to reduce re-experiencing symptoms, this new information needs to be connected to the worst moments in trauma memories in an emotionally engaging way. They discuss ways they can bring the information discovered in therapy back into the trauma memory.
And I wonder, is there anything else that we can do to really bring this, or to show ourselves that he survived and that he's living a meaningful life now? Is there anything that we can bring into this?
Patients may struggle to think of ways to update their memories. If so, it can help for therapists to suggest ideas.
Maybe bring to mind when you were actually holding Hugo and when he was breathing, and kind of maybe even just doing the position of kind of holding him, and maybe even visualizing or feeling that weight of him there as well.
Right, maybe to kind of move it on to the moment where they bring him to me or something, and he's moving and he's very much full of life at that point.
Yeah, definitely.
Therapists and patients creatively draw on the different senses and modalities that will help the updated information sink in emotionally.
Obviously I've got the videos that I can look at. I mean, I can, he's asleep right now, but I could go and peek at him in his room. But I guess I've got things actually even around the house as I'm looking now, like pictures he's drawn and things like smell of him. I can even grab a couple of things.
Yeah,
now.
that'll be brilliant. So if you could go and grab some of those things that really highlight there that he's strong and he's healthy and he's survived.
I'll get a couple of bits. Yeah.
Brilliant.
Step 3. Patients hold the hotspot and its associated meanings and emotions in mind while bringing in the updated information.
What I would like to suggest maybe is that we try to connect these powerful memories with the updated information, just to show that with the imagery and the movement that he, by kind of looking at his pictures and maybe smelling his pajamas, that to remind ourselves that he's survived and that he will go on to continue to have a meaningful life, and we kind of kind of to link that a little bit more with that distressing hotspot and start to update that and add some more detail to make it really more visual and a bit more tactile for you as well.
Yeah.
Would that be okay?
Yeah. Yeah.
Brilliant. So when you're ready, can you hold that hotspot in mind and describe what you can see?
Okay, so I can see Hugo being taken away, and I can just about make him out in the corner of the room, and I can see he's really grey. He's not moving, and I just start to panic.
And at that point, what was the worst fear in your mind at that time?
I think he's dead.
Yeah.
And that even if he survives, like he's gonna not be able to have any kind of life, meaningful life. He's just could be potentially really damaged by this.
Really well. And I guess as you're thinking this, how are you feeling as you're thinking this?
Just like horrified and sad and panicked, really.
Yeah.
The therapist has helped Emma to connect to her worst meanings and associated emotions before they bring online the updated information, using a range of modalities to help it sink in. Fast forwarding past the worst moment.
Doing really, really well, and I think what I'd like you to do now, as you see Hugo there and grey and lifeless, I'd like you just to move that memory forward to once you kind of received him and you got him in your arms. Could you do that for me and kind of describe that for me as well? Move that memory forward.
Okay. Yeah. So I can see the nurse walking over, and he looks more full of life. He's not so grey. She passes him to me. Yeah. I take him in my arms, and he's like moving and like holding my face, and he feels heavy, and he's trying to feed, and he's clearly alive, and I just feel relief just to have him in my arms and feel him there.
Fast forwarding memories from the worst moment to a moment when the meaning has changed can be powerful. For some patients, this might involve moving away in imagination from the place where they felt at threat and travelling home to where they were later safe. Using imagery, photo and video.
I bring in the image of Hugo as a 3-year-old and really running around and being active, something just to remind ourselves of Hugo being very alive and very strong and healthy now.
Yeah, so I can picture that video I was just looking at on my phone of him dancing around and climbing over everything, being typical Hugo. I can really sort of see that. I could even kind of just look at a few seconds of it now.
Yeah, that would be brilliant.
Yeah, I'm just playing a little bit of that now, which is really nice to see.
Okay, go! What are you going to say on video? I need
Looking at footage of Hugo as an energetic 3-year-old doing meaningful things demonstrates her updates in action and leads to a powerful emotional shift. Note that the therapist tries to engage Emma's senses to make the updates feel real and help updated meanings sink in emotionally. This is adapted to the idiosyncratic meanings and often means creating sensations incompatible with the trauma. For example, movement if someone was trapped, or a different taste when someone tasted blood. Video illustrations of this are available in the modalities of updating video on the Oxcadat Resources website. Imagery rescripting can be a powerful way to update hotspots. For example, images of a loved one at peace to update hotspots where they were in pain or afraid before their death. For more examples, please see the videos on modalities of updating, traumatic bereavement, mental contamination and mental defeat. Step 4. Review ratings of distress and nowness after updating to ensure the new information has sunk in emotionally.
That's brilliant. And I guess, how true does that feel now for you?
Holding all these, things here, and the image of him, definitely true. Like, yeah, 100%, I think.
And that's and in terms of kind of with this hotspot as well, how distressing does that feel for you now that we've done this?
Much less, actually. Like, now, having gone through all of that and with the updates, much less, like maybe 20-25% probably. Like, okay, I'm going to stop that video there. You see them just going on to the final step, which is really discussing how to keep updating memories over the week for the homework to make sure these updates really sink in. And when patients are getting any kind of re-experiencing over the week, they're bringing in the updates rather than doing what they might do usually, like pushing memories away and those kind of things. So hopefully, I mean, a bit of repetition there with what you've already seen, but hopefully just to show you that video, maybe a useful one to show supervisees or point them to in supervision, just to really highlight what all the key steps are, because these are commonly steps that sometimes get missed, like really connecting the key with the lock at the right moment, really bringing on the emotions, really using those different modalities to make it feel really powerful for the patient. So as a supervisor, you're always looking out for, have all these things been done in the session? What might have been missed to really get the most out of updating? Okay, moving on to another common issue that we find, which is getting out of the therapy chair. Okay, so really powerful experiential exercises can sometimes be missed out in treatment, or therapists might tend to kind of set these things for homework. So suggesting doing a behavioural experiment, for example, for the patient for homework, rather than doing them together in the session. Well, why is it helpful to do these things together in the session? Well, in our experience, we tend to find that this is the best way to lead to the biggest cognitive shift, the biggest change, because actually doing something together with somebody, you're much more able to ensure that they're dropping all of those key safety behaviours that they might commonly be using during, for example, a behavioural experiment, or to make sure they're getting the most out of these exercises by really generalising their learning, for example. So it really can be really powerful to do these things together and get out and about together. Also, as therapists, we often see things and identify things that we didn't know the patient was doing when we weren't going out and doing these things together with them. So that can be really, really helpful, like spotting a safety behaviour, for example, you never knew your patient was using until you go out with them. A nice example of mine was a chap that I'd worked with who'd been assaulted. Every time he went out, I didn't realise he was kind of putting his hood up and scowling at people to try and kind of put people off from attacking him. And I only realised he was doing this when we were out and about. Obviously, this was then leading to a whole host of other behaviours from other people. Sometimes he was getting people comments on this that was making him feel more at threat. So it was really key to spot that he was doing that. Okay, so how do we get therapists to get out of the chair more? Well, we get out of the chair more in supervision. So actually the best way to ensure that therapists are doing these things is to do it together in supervision, to model it live. And this is a really good way to test out any fears that therapists might have, or spot any fears that therapists might have. But supervisors often also feel quite anxious about role play. So you might need to test out some of your own supervisor cognitions. I often have thoughts like, people are going to hate it if I suggest a role play. I'm going to make everyone feel really uncomfortable. So maybe it would be better just to discuss this. So I've often had to push through and test that out myself. And what I tend to always find is that even though people might feel a bit uncomfortable about doing role play, it is the one thing that people always say was the best route to them learning things most deeply. So it's always worth doing. Okay, I'm just going to share a few ideas and things that have worked really nicely in supervision for doing little kind of experiments, role-play experiments together. One idea is doing an out-of-office experiment together. Now that can be time consuming in supervision, but we've definitely managed to do it briefly by either going for a quick walk down the road and just modeling how you might do a behavioral experiment, dropping someone's safety behaviors together, or even remotely in supervision. So here you can see in the video an example of that. And recently in a supervision group, I went out of my home and went for a little walk with my headphones on, and my supervision group were trying to get me to drop my safety behaviour of scanning for danger, and encouraging me to do then and now when I told them I was triggered, and it worked really nicely, and actually was only took about 15 minutes, but really, really helpful little role play. The scanning on and off experiment, which I think we all did together actually in one of your earlier training days, can be a really nice one to do in supervision if you've got a supervisee, particularly who's at home, perhaps remotely, where they go into their kitchen and start off by making a cup of tea as they normally would, and then making it while scanning for danger. I think we all did that together before, didn't we? It works so nicely in supervision as a little role play. And what I tend to find is that having done that, everyone then goes away and tries it with their patients afterwards. Just kind of modeling it is so powerful, and then people then taking that forward and doing more active stuff in therapy. You could do a nice little virtual site visit together. Virtual site visits are things that therapists often avoid for a range of reasons. There might be fears about the technology, there might be thoughts that it's just not going to be helpful, or just feeling a bit unsure of how to do it. And doing one together in supervision can be a great way to kind of do a little role play, whether you're in person and looking at the screen together, or sharing screen and doing that together. And that could work really nicely, as well as doing a bit of a role play around triggers practice, perhaps looking at some images of triggers together, or bringing some triggers in to supervision and doing a bit of role play around that. As I mentioned earlier, reclaiming life is a really key manoeuvre we want to have on the agenda throughout the whole course of treatment, but it's something that supervisees sometimes forget to kind of keep on the agenda. And there can be all kinds of blocks to doing reclaiming life. So we often might do little reclaiming life experiments to test out some of the blocks patients have, or supervisees have, to reclaiming life. So here is a little example of an experiment we did together in supervision recently, where I got everybody to do 60 seconds of movement in supervision to test out our own sort of fears as therapists. And one of my therapists said that they just didn't have time in a cognitive therapy session to do some reclaiming life together, and they really felt like it's just not going to help if we do something brief, so it's not going to be a worthwhile thing. So we just did 60 seconds of movement together in the supervision, and what was really helpful was actually afterwards everybody was able to say, well, actually I do feel a little bit more energized, a little bit better just from doing that 60 seconds. So just to keep you all awake, I'm actually going to play this video this was my friend Emily Williams, who very kindly just did 60 seconds of movement for me. I've thrown it on YouTube, and I'm going to put the link in the chat just in case anyone wants to use it in their supervision. And I'm going to suggest, if you're not too hot, so please don't feel you need to do this if you're absolutely boiling. You might just want to use the opportunity to stand up and stretch. So let's just do this together if you want to, but don't if you're overheating.
Hello, I am Emily, and I'm going to take you through a really quick 60 seconds of movement to get some energy in your body and some oxygenated blood into your brain, because we all need it if you're stationary all day or on Zoom calls all day. So, first of all, let's shake your body. Get some blood into your fingertips and your toes. Feet underneath your knees. Take a deep breath in. And then stand up, arms above your head, onto your toes if you can. Do this 5 times. Squeeze your glutes and your quads because you're not using them when you sat down. Once you've done 5, you take one foot in front of the other, toes up, hands to chest, breathe in. Stretch your chest. Open up as you come out. 3 of these. And then 3 the other side. Last one. So now you can do jumping jacks if you want to, but let's do punches. Come on, let's go for it. So 10 punches. Really go for it. And then stretch hands up together. Stretch to one side. The other side. Let's go again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Last one. Let's go for it. Come on. Good job. Remember, some movement, however small, is always better than no movement. Tell me you don't feel more energy now.
Okay, well done if you gave that a try. I'm even more sweaty than I was before. So, but it just goes to show, hopefully, if anybody did give that go, I certainly feel a bit more energized. I don't know if anybody else does. And it just goes to show that even doing something brief, getting out of the chair,
Hello, I am Emily.
getting out of the chair can be really helpful. A few key tips for role play. Role play often causes a huge amount of anxiety for all of us. So this is very, very normal, and it's really important to normalize that anxiety with your supervisees. It can be really helpful, I think, sometimes rather than jumping straight into a role play, to show a brief demonstration video first, if you can find a brief one, so people have got a vague idea of what they need to do. Or a strategy that I've sometimes used is this tap in, tap out. So if you've got a supervision group, if you're the person who's playing the therapist in the role play gets stuck, they can say, I tap out, can someone else tap in? You can even do that if it's just the two of you and switch roles. So it sort of feels like less pressure on the person to keep it going if they get stuck or they freeze or something like that. And really, again, just like we did with the videos before, focusing on what went well after you've done a role play, because remember, your therapist will start to be hard on themselves immediately, probably after what they've done some role play. So really focusing on the strengths before you focus on what could we build on next time. Someone's just said in the chat that they need Emily in their life daily. I think I do too, to keep me moving. Right, so we've talked a little bit about spotting therapist cognitions throughout, haven't we? Whenever there's blocks to doing things like using questionnaires, like kind of doing behavioural experiments live together. It's really important to keep our eye out for therapist cognitions that might be getting in the way of something in treatment. So as a supervisor, not only have you got to get into your patient's head, you've got to get into your supervisee's head. So how do we do that? So I'm going to show a little bit of a role play here, video, and I'm playing the supervisee here, and my colleague Alice Kerr is playing my supervisor. And we're looking at some fears that I'm having about doing some memory work. So I've avoided doing a little bit of memory work with somebody, and she's trying to help me unpack that and what might be going on for me, and then work on that with me. So I thought it might be a nice opportunity to watch a bit of video and note down anything the supervisor does that you think is helpful, any key questions or anything that really is useful. Feel free to pop those things in the chat if you want to as you watch as well. Okay, here we go. So my question was really whether I should move to narrative writing for reliving for him, because he just seemed, I just thought reliving might be too difficult.
Okay, so can I just check, Emma, this is his third session, isn't it? Yeah. Remind me, sorry, what have you done so far with him? Have you done any memory work in sessions yet? Yeah, we started getting a first account in reliving last session, but he got too upset, so we stopped. Okay, I'm sorry to hear that. What were the signs? Tell me more about that. What were the signs that you thought memory work was too upsetting for him? He just looked really upset. Okay, that sounds difficult. I'm wondering, do you have any tape that do you have a clip that we could look at together? You see that? Yeah. We'll just go back a little bit here. So I think this is just where I, just before he gets upset. Pretty well, Alex. Okay. What happens next?
Well, that's when he holds me down. Are you okay, Alex? It sounds like this is a really tough point. Would you prefer to stop? Yes, please. Yeah, that's absolutely fine. Why don't we stop there, and then we can kind of move on to. I'll stop it there, Alice. Okay. That probably shows most of it. Emma, that was so helpful to see that clip. Thank you for having that prepared. Let's start, before we start talking about it, what was positive about that? What did you like? I mean, he was doing it and he was engaged, but I definitely thought, looking at it, actually, that I probably could have kept going with the reliving. Okay, that's really interesting. So what was going through your mind then, just then when you were watching it back? He didn't seem as upset as I remember, and I thought, actually, if I'd kind of moved it forward to the end of the story, we might have even been able to have put in some updating, maybe. Okay, that's a really good point. I think it's really interesting you've noticed that now.
let's think, how were you feeling in that moment when he got upset, and what was going through your mind?
I was feeling quite anxious, and I was thinking like he just can't cope with it. He just looked really distressed to me.
Okay. Yeah, I think that's really understandable, that when he was getting that upset and you knew it was a key hotspot for him, what did you what got in the way of then kind of continuing with that work with him, do you think? What was your fear?
I guess just that he might get really upset, that it was too much.
Okay. Well, I think we've all had that concern before, Emma. Absolutely, all therapists, and I know I certainly have. I'm wondering, when we watched that back then, it sounds like you noticed perhaps he wasn't as distressed as perhaps you remember him being. And I'm wondering, in that kind of moment, if we had our time again, what do you think could have happened if you had carried on with the memory work? What's another way of looking at it? What might have happened?
I guess he might have got past that worst point, realised he could actually cope with it. We might have even done some updating, I guess, so it could have taken it a step further.
Okay. So yeah, those sound like really important points then. Do you think there are any other reasons I'm wondering, he looked down, didn't he, in that moment? I'm wondering, do you think there was anything else that could have been going on for him? Any other reasons he might have looked down?
Don't know, really.
Okay. Let's maybe think about the formulation, the model that you mapped out from his questionnaires that we looked at before. If you have a quick look at that now.
Oh yeah, shame comes up on the questionnaires, actually. I put that in the model.
Okay, yeah. And I think we've said, haven't we, before, that sometimes when people feel really ashamed, they often look away or look down and they avoid eye contact. I'm wondering, now that we know that, we're thinking about that, could there have been any other advantages in terms of his shame for you to have carried on with that memory work?
Yeah, I hadn't thought of it at the time, but I guess we could have done some normalising, couldn't we?
Yeah, I think that's a brilliant idea. Yeah. So pulling all of this together then, Emma, what do you think was giving you the impression that it was too much for him at that time?
I think probably my own kind of thoughts and feelings, actually. I was a bit more focused probably on how I was feeling. I was a bit anxious about pushing him, maybe, more than I was focused on him.
By watching the video and formulating what happened, the supervisor has helped the trainee to see that the patient's appraisals driving their current sense of threat, I cannot cope with memories and being abused means there's something wrong with me, led to the patient looking down and distressed when they got to a shame hotspot. The therapist's own cognitions then contributed to stopping the memory work, which in turn keeps both the patient's and the therapist's fears going.
What do you think you could try and do differently next time?
I could set it up as a behavioural experiment with him, I guess, couldn't I? Let's do the reliving, like what are his fears, which would be a good experiment for me as well. And then that gives us the opportunity to bring in some normalising around the shame, and maybe even a bit of a simple update, like after that reliving, like the fact he did escape from his abuser on that occasion.
Yeah, brilliant idea. Okay, how about we role play that now?
Yeah, that would be helpful, actually.
The therapist carries out their own behavioural experiment in the following session to test their fear that if they continue with reliving, the patient will get so upset they will break down and disengage with therapy. She finds it helpful to discover that the reliving went well. The patient found it helpful and did not disengage. In fact, his scores reduced. She learns more generally that people who have experienced multiple childhood sexual abuse can benefit from memory work early in therapy.
Okay, excellent. So hopefully you could spot in there some really helpful things that my supervisor was doing, but most importantly, really modelling and mirroring, I guess, the key interventions in cognitive therapy. So spotting meanings, drilling down into them, testing them out in a behavioural experiment, and using supervision as an opportunity again to kind of model doing the things that we want the supervisee to be doing in therapy. Okay. So in the last few minutes, I'm just going to cover coming on to therapist self-care. Okay, so thinking about therapist self-care is always important, but it's particularly important when we're talking about trauma. And traumas are often
personally upsetting to us, because trauma is part of human experience. We've all been through difficult things in our lives, and we can find that we are working with somebody for whom their trauma is really personally upsetting for us. It's always really important as supervisors to keep in mind that therapists can obviously ask not to see a particular trauma. I had a very traumatic birth with my first son, and for a while I said to Anchor, I don't feel able to see people with traumatic birth. When I was pregnant again, I didn't take on people who were going through traumatic births, and that is completely okay as therapists and supervisors. It can also be helpful sometimes if sort of your supervisor is working with a memory and it activates some of their own difficult memories, to encourage them to use then and now, focusing on how their experience is different to the patient and drawing on their own updates as needed. It's always good, as well as supervision, to be mindful of the therapist's emotional temperature in therapy, whether they may be, for example, either over or under engaging with memories that may be personally difficult for them or they find particularly horrific. For example, in previous supervision groups, we've had people who were blood phobic, who found it quite difficult to get into the details of hearing about blood, and really important as a supervisor that you're just keeping an eye out for those kind of things. We also often see that supervisees may take on many people who've been through the same kind of trauma. Sometimes you see an elevated sense of risk in supervisees. So over the lockdown period, I had a supervisee who was treating a lot of rape and assault trauma. And she mentioned a few times in supervision that she really hadn't gone out of the house, and that this had really kind of wasn't just related to COVID, and we were able to really spot that her sense of risk to herself had actually increased because she was seeing so much of the same kind of trauma. And actually in supervision we needed to do a bit of a risk calculator and do some behavioural experiments for her, and also think a little bit about balancing her caseload a little bit more, because her sense of risk had somewhat shifted just from seeing so much of the same type of trauma in one space of time. Obviously all of the above that I've just spoken about applies to supervisors as well. Often we're hearing lots of stories in supervision, and that can also have an impact on us, so really need to be mindful of those things. And we just want to constantly be keeping therapist self-care in mind in supervision, so modelling that. Perhaps if you've got a long supervision, planning a break in the middle, thinking with supervisees, if you've talked about something really personally distressing or just generally distressing, what are you going to do after supervision to look after yourself? What are you doing after that session with that person to look after yourself? And just keeping an eye out as a supervisor for any warning signs that the people that you're working with may not be looking after themselves. Like they're always eating lunch in supervision, they're not taking breaks, those kind of things. We often as therapists may have cognitive blocks to looking after ourselves. So again, like you saw in the video with Alice, spotting any therapist cognitions that may be getting in the way, and just again drawing on all the same kind of things we would be using with someone we were working with in therapy, like the metaphor of the oxygen mask on yourself first as absolutely essential for looking after others, or helping therapists use things like positive data logs or therapist self-compassion as needed to help nurture their confidence. And these are things, again, that often therapists just aren't using. You know, I don't know about everybody here, but so many people tend not to do things like kind of giving themselves some credit for things that are going well in therapy, keeping a positive data log, writing yourself a bit of a compassionate letter to yourself if you're having a really hard time. So I would actually really encourage you after the session today, if you've never tried these things for yourself, perhaps give it a go. Start keeping a bit of a positive data log for yourself of things that are going well in your cognitive therapy supervision or therapy. Perhaps write yourself a bit of a compassionate letter, and I've put up on the handouts a couple of examples. Is one I wrote for myself during the darkest days of lockdown that I found particularly hard, trying to be a bit kinder to myself. So those are some tasks for you if you've never tried those things before, can be really useful. I'm going to finish up now because we need a bit of time for questions at the end of the day, but that's been a bit of a whistle-stop tour, and as I said, there's a document that goes into these things in a bit more detail in your handouts, but it might be useful to just write one or two key things down that you've taken away, key tips for supervision really going forward. And thank you for bearing with me at the hottest part of the day. I am incredibly hot and sweaty. I'm sure everyone else is. So thank you.
Thank you so much, Emma. There is one question in the chat that I picked up about it's about using the questionnaires to spot cognitions. Would you take a statement in a questionnaire that scored highly and ask the client to rephrase it to meaning that fits to them, or does the statement usually give you enough to work from?
Oh yes, it's a good question. So items on the PTCI cover a range of cognitive themes, and the items, for example, I think one of the items on shame is something like people will look down on me because of what I've been through. So these give us kind of indicators, if you like, clues for meanings that may either have come up at the time of different hotspots for people or afterwards, maybe things people have dwelt on afterwards. So I think what I'd be doing there is really looking at if I can see shame is coming up, but I've not identified shame in any of the hotspots, I'd be going back to the person and looking at their hotspots with them and just exploring, you know, whether actually at any of these points, did they feel shameful? Did they have any thoughts that were missing, and just really start to unpack that a little bit more, or thinking about, you know, did shame as a feeling come up for you at any point during the trauma? And that might give me a clue as to where there's a shame linked meaning, if you like, that you need to unpack. So I think it gives you some clues. It doesn't always give you the full meaning for the person. You want to really drill down and unpack that again, get into the core of the onion again with them. It gives you the clues of what the themes might be, but actually we really want to drill into that person's very idiosyncratic meanings in their hotspots. Do you think that covers it, Anka, or did you want to add it?
Yes, yeah, I think I agree fully with that. I think rarely it's exactly the same wording that fits to the particular hotspot, but you get the idea where you will have to look further. Any other questions for you for any part of the workshop today? Well, we'll look out for those. Emmy, did you do the Qualtrics link yet?
Yeah, I'll post it now.
Yeah. We would, while we're waiting for further questions, just would like you to ask you again to give us some feedback on this workshop. We for two purposes. One is to feedback to Health Education England, what the feedback on this particular workshop is, but also for us to fine-tune the workshops. We have already learned from previous feedback, but it's always good to get your views because we learn from it as well and can hopefully improve the workshop further. So if you could click on this link, and it's I think about 5 questions or so, it's very, very brief, that would be very, very helpful. Maybe if you could do it now, that would be even the best. We'll send it out again as well, but if you could take a few minutes to do that just now. So there is a question, what would be the advice for questions that we ourselves have not yet come across in our own work with PTSD as a supervisor, and or perhaps not yet worked with, for instance, the moral injury? Don't know who wants to answer that. Maybe I'll make a start. I think when working with PTSD, I think our experience over the years, there's always somebody. You think you have seen a lot of patients and have come across nearly everything, but there's always something that you haven't quite kind of thought about yet in that way, that like a client represents. And I think this kind of reflection is going back to the basics, like how can we formulate that individual's problems, and how does it link to what we already know, can sometimes for us in our supervision break this kind of, you kind of get kind of a bit of mental block. Oh, I haven't come across this before, this must be really difficult. Like breaking it down into the formulation, and then like how does it link to things we already know how to do well. So for instance, in the moral injury paper, there's a lot of overlap with the work on guilt, shame, and also anger. it's just like all together. So but by knowing the different components, we can then think about the individual case with a moral injury. So I think that's something that has happened in our supervision groups. But Emma and Sheena, Rachel, you might have other responses to this. It's a really good question. Any additions?
I think I was just going to say, you know, we don't always have the answers to
Yeah.
everything, do we? I think that's the thing, you know, the human suffering is a puzzle, and we don't always know everything. As Anka said, we haven't always worked with every example that's going to come up in supervision. So be Socratic, explore with people, like Anka said, you know, what does the formulation say? What are the core meanings? Let's try and unpack this together. You know, what have we tried with other you know, similar meanings that have worked or not worked in the past? And obviously there, as Rachel said, there's great resources on the Oxcadat resources website you could look at yourself or point people to. But I think exploring it together in supervision, and Anka often does that with me, you know, I'm not quite sure here, what could we try? It's a puzzle and we're being detectives together. So be kind to yourselves, I think, as well. You don't have to know everything. None of us do.
Yeah, and I guess also going back to the patient, then there's something that the puzzle that you feel as a therapist must be puzzling to them as well, and exploring it further, maybe in addition. There's another question: will you still have access to the resources when you have completed the supervision? The answer is yes. We haven't changed the password now of the generations. We have the third cohort going through the training, so the password is still the same, and we intend to leave it that way, and we'll maintain the website as long as we have some kind of basic funding to do this. So the plan is yes, and we're constantly also expanding the general resources website. So just like the video Emma just shown, it's realized we didn't have a video, really a short video of all the steps of the updating, and that was a gap we spotted actually through doing these trainings and the feedback we're getting. So if you notice anything when in your further practice that you think isn't fully covered, or we would like to another video, and we appreciate these suggestions, because we want to make it as useful to everybody as we can. And yeah, supervision, some will coming towards the end of your supervision and will be now submitting a recording for and we want to really emphasize it's a formative assessment. Sheena emphasized that as well. It's not like to judge you, but we're hoping it will be really useful to look at the session with the framework of what we're trying to achieve and where there's room for improvement. So I hope you'll find that a helpful part of the training as well.
There is another question in there, Anka.
Oh, okay.
If rating distress nowness during the reliving can disrupt the process, could also looking at photos and videos in the present.
Yeah.
I mean, it's an interesting question. For me, I think it comes back to the timing of the intervention again, because actually when you're looking at photos and videos, you almost want to interrupt the process because you're updating it, you're getting them to sit back and reflect. So it's during the relivings, particularly the initial relivings, I want them to tell their story. I want to encourage emotion and I want that out. So I want to interrupt less. As the therapy goes on, I might be interrupting a little bit more. So it's just thinking, it's that meta competence again. It's kind of like timely, intervening in a timely way.
Yeah, thank you for spotting that, Sheena. Thank you. I probably missed now some more questions coming. Thank you for your feedback. That's great. The memory trigger diary Emma uses. Okay. I'm not sure. Hannah used it in her workshop. Did we have it in the handout? Then I will have to dig it out and send it to you. The intrusion trigger diary. Thank you. So I think we should come to now. I hope I haven't missed any other question here. So thank you very much for your attention, for coming today and for participating in this training. But my special thanks today go to Sheena, Emma and Rachel for their presentations and for all contributing to the program. Thank you so much. And I hope you will, it won't be too bad with the heat for everybody today. Thank you. All the best. Bye.
Bye.
Thank you. Bye.
Bye.